Hello students, I am Dr. Jansiya, Assistant Professor, Department of Orthodontics and Dentofacial Orthopedics, Vinayak Mission, Sangracharya Dental College. So today the topic is Interceptive Orthodontics. So what is Interceptive Orthodontics? That is, early Interceptive Orthodontics is an approach that can be extremely effective in children. So Interceptive Orthodontics is undertaken at a time when the malocclusion has already developed or is developing. Basically refers to the measures undertaken to prevent a potential malocclusion from progressing into more severe ones. There are certain definitions are there. According to American Association of Orthodontics in 1969, defined interceptive orthodontics as that phase of science and arts of orthodontics employed to recognize and eliminate the potential irregularities and malposition in the developing dentofacial complex. According to Profit and Ackerman in 1980, defined interceptive orthodontics as the elimination of existing interferences with the key factors involved in the development of the dentition. There are basic interceptive procedures that are undertaken. There are serial extraction, correction of developing crossbite, control of abnormal habits, space regaining, muscle exercises, interception of skeletal marrelation, and removal of soft tissue or bony barrier to enable eruption of teeth. Now coming to space regaining, if a primary molar is lost early and the space maintenance are not used, a reduction in arch length by mesial movement of the first molar can be expected. In such patients, the space lost by mesial movement of the molar can be regained by distal movement of the first molar. The space regaining procedures are preferably undertaken at the early age prior to the eruption. So in this picture you can see that there is a space lost due to the decayed deciduous tooth. So in this area we can use the space maintainer to prevent the mesial eruption of the molar for the future erupting of the teeth. There are types of space regainer. In that we have fixed appliances and removable appliances. In fixed appliances we have Graber space regainer that is most commonly used, and open coil or hep space regainer and jack screw space regainer. In removable appliance we have Hollis appliance, in that incorporated with helical spring, splint acrylic dumbbell spring with the single slot elastics, paddle spring and expansion screws. Coming to correction of developing crossbite. So what do you mean by crossbite? Any anterior or posterior should be corrected as soon as they are detected. It may be better to treat them as the permanent teeth begin to erupt into the oral cavity. The child may be too young and uncooperative at the deciduous dentition stage. Crossbite can be unilateral or bilateral. These can also be true or functional in nature or a combination of two. Anterior crossbite can be broadly classified as dentoalveolar anterior crossbite, skeletal anterior crossbite and functional anterior crossbite. In this picture you can see that in deciduous teeth, that is lower incisora overlapped by the upper deciduous teeth. So this is called as crossbite. So in this period interceptive orthodontics treatment is very important to correct this crossbite. Otherwise in future it leads to malocclusion. We have go for the extraction or fixed appliances. Coming to thumb sucking, one of the habits that is most frequently practiced by the children, and it is capable of producing damaging effects on the dentoalveolar structures. There are some common habits or developed during the deciduous period, that is thumb or digit sucking and tongue thrusting, mouth breathing, lip sucking or biting. So students, once the kids developed that habit means, so followed by that we have developed tongue thrusting habits, that is the tongue is protruded to the upper and lower anterior teeth, and followed by the kids will develop the mouth breathing habits, and followed by proclination of the upper teeth. There will be lip trap will be happening, so lip sucking or biting will be happen. So in this period we need to do the interceptive orthodontics. In this picture you can see that there will be midline diastema is there, so has developed due to thumb sucking, and there will be anti-clockwise growth of the maxillary segment you can see. Coming to muscle exercise, the normal development of the occlusion depends on the nature of the muscles of the face. The muscle exercise allows a clinician to bring such aberrant muscular function, that means abnormal muscular function, into normal functioning. Uses to guide the development of the occlusion, to allow optimal growth patterns, to provide intention and stability. So this is very important, intention and stability in the post-corrective orthodontic cases. So these are the exercise will be given, that is exercise for masseter muscles. That is, tell the patient to clutching the teeth to train the tone the maxillary muscles. And second exercise of the lip to become the stability and around the circumoral muscles, and exercise of the tongue. These are the muscular exercise will help to stability of the oral function and future erupting of the teeth. Then coming to serial extraction. So serial extraction is very important in the deciduous as well as mixed dentition period for the future avoid of crowding as well as malocclusions. So according to Tweeds, it has defined it as a planned and sequential removal of primary as well as permanent teeth to interrupt and reduce the dental crowding problem. So the serial extraction will be advised to in the mixed and permanent mixed and deciduous period for the reducing the dental crowding problem. Dental crowding exists where there is an excess of tooth material in relation to the amount of basal and alveolar bone that supports the teeth. So in this picture you can see that it is both permanent as well as deciduous teeth. So there are some serial extraction procedures are there. Some of the most common and accepted sequence are Tweeds method. So Tweeds method and Dwell's method, in that we have 3 serials, and Nance method. So we'll coming to Tweeds method. So we'll come serial extraction. What are the indications? Serial extraction are indicated in a class 1 malocclusion with an arch size and a deficiency of 5 mm or more than per quadrant, or normal eruption sequence are assessed radiographically and skeletal growth pattern within the normal limits. Number 2 is arch length deficiency is there. If there is arch length deficiency, which could be unilateral or bilateral, it will be in the upper arch or lower arch, is indicated by there is a non-pathological problem, that is midline shift of mandibular incisor due to displaced lateral incisors and premature loss of deciduous canine, and abnormal canine root resorption or canine being blocked out labially. In these cases you can use for serial extraction. In next slide, in pathological, extensive proximal caries or subsequent mesial migration of the teeth distal to the caries lesion, or premature loss of deciduous teeth, or lack of subsequent space maintenance, deleterious oral habits, and improper proximal restoration and tooth ankylosis. If this causes in the deciduous period, you can go for serial extraction. In which are the cases you should not do means a mild to moderate crowding, a tooth size a discrepancy length less than 5 mm per quadrant. If less than 5 mm is there, you should not avoid a serial extraction, as well as in class 2 division 2 and class 3 malocclusion and space dentition. In congenital absence, anodontia and oligodontia. Anodontia means completely absence of teeth, and oligodontia means 6 or more teeth will be absent, not every teeth. So coming to the Tweeds method of serial extraction, in this picture you can see that in Tweeds method we have step 1 and step 2. In step 1 you can see that extraction of deciduous first molar. We are extracting deciduous first molar for the alignment of the anterior tooth region. In step 2 we can extract deciduous canine as well as the first premolar for the alignment of the anterior incisors. This is step 2, extraction of deciduous canine as well as first premolar for the relieving the crowding. Coming to Dwell's method of serial extraction, in this we have 3 steps. The step 1 is extraction of deciduous canine for the alignment of the lower incisor. If you extract the deciduous canine means we can align the anterior region, both the upper and lower anterior region we can go for alignment. In step 2, extraction of the first molar to accelerate the eruption of first premolar. When the first deciduous molar is obstructing means we can extract that to allow the first premolar to erupt. Coming to step 3, in this case extraction of erupting of first premolar to permit the permanent canine to erupt. So this first premolar, where obstructing the canine means we can extract the premolar to smooth erupting of the canine. So this is step 3. So in this cases we can complete the serial extraction of the Dwell's method. So what are the advantages means the more physiological treatment as teeth are guided into normal position using physiologic forces, and duration of fixed treatment is reduced, and health of investing tissue is preserved, and lesser retention period is required, and result are more stable. Coming to disadvantages of serial extraction, a good clinical judgment is required. No single approach can be universally applied. The treatment time is prolonged over 2 to 3 years by giving both myofunctional as well as fixed orthopedic appliances, and patient cooperation is also very important, and tendency to develop tongue thrust as extraction space closes gradually, and extraction of buccal teeth cause deepening of the bite is one of the disadvantages in the serial extraction. So coming to interception of skeletal malrelations, the developing skeletal malocclusion, if detected at an early stage, that means in mixed dentition as well as deciduous period, can be intercepted so as to decrease its severity at its time, even resulting into the normal occlusion. So these changes can be brought about by myofunctional therapy. That means if there is any discrepancy in the jaw, either maxilla or mandible, by giving myofunctional as well as orthopedic appliance, we can correct the skeletal malocclusions in the deciduous as well as the during growth spurt period. That is very important in interceptive orthodontics. So according to Mills in 1991 has defined as functional appliance as a removable or fixed appliance which changes the position of the mandible so as to transmit a force generated by the stretching of the muscles, that is called myofunctional or fascia or periosteum. So by giving myofunctional, position of mandible will be changed forward through the acleric and wire work of the dentition and underlying skeletal structures. By giving myofunctional therapy, we can eliminate the skeletal discrepancy. So coming to interception treatment for class 2 malocclusion. In class 2 malocclusion generally occurs as a result of either increased maxillary growth or decreased maxillary growth or a combination of the same. So for example, if there is a class 2 malocclusion, so we can give in the face bow along with the headgear retract the excessive growth of the maxilla, whereas functional appliance bring about the anterior position of the mandible. So in this patient you can see that patient wearing the face bow, and this anchor is taking support from the frontal area, and this chink up to eliminate the mandible to come forward and bring the maxilla into the orthognathic profile. So in class 3 malocclusion, generally results due to deficiency in the maxillary growth or excessive mandibular growth or combination of the same. So in this picture you can see that there is a Frankel appliances. In this we can use Frankel 3 appliances used for promoting growth of the deficient maxilla, and a chin cup is generally used to restrict mandibular clockwise growth. So with the combination of Frankel appliance as well as the chin cup to restrict the mandibular clockwise growth. These are the types of Frankel appliances. Coming to removal of soft tissue and the bony barriers. So surgical procedure involves excision of soft tissue and removal of bone overlying the crown of the unerupted teeth. In this picture you can see that patient is under the fixed orthodontic appliances because of the impacted canine. So what we doing is surgical removal of the gums upon the tooth, and we placing the bracket and giving the ligature wire to bring the tooth into the alignment. So certain cases we can use the soft tissue removal in interceptive orthodontic treatment. So conclusion, students, the interceptive and preventive orthodontic procedure enable the clinician to treat and make a developing malocclusion less severe, so as to allow the corrective orthodontics to deliver a stable and more conservative non-extraction treatment plan benefiting for the patients. If interceptive orthodontics is done in the mixed and deciduous period, in future we can avoid surgical as well as extraction of the teeth. So as a doctor we need to be very careful during the growth spurt period as well as the mixed dentition period to correct the future crowding and malocclusions. Thank you students for watching my class.